Welcome friends. Today we will be seeing on the topic CML, that is chronic myeloid leukemia. So before going into the topic per se, let's discuss few basics about the normal cell development. So the hematological series of cells develops from the common stem cell. So this stem cell gives rise to two types of cells. Those are the myeloid series of cells and the lymphoid series of cells. From the myeloid series of cells, we get three other cells. Those are the RBCs, the WBCs and the platelets. The lymphoid series of cells give rise to the B cells and the T cells. How does this normal cell develop? A cell has a receptor which is activated by the growth factors. So if this is a receptor, there are growth factors which activate these receptors, which then activates the tyrosine kinases, and this causes proliferation of these cells. This is under normal circumstances. What happens when there is an abnormalcy in this? When the tyrosine kinases are auto-activated, then there is a loss in the inhibition of these normal development of cells, and this causes abnormal proliferation of these cells. So this tyrosine kinases have got auto-activated due to problems in the genetic mechanism, which we will be dealing in detail. What happens to each of these series of cells? When there is a problem in the RBCs, they give rise to polycythemia vera. When there is a problem in the WBCs, they give rise to CML. And in the platelets, they give rise to essential thrombocythemia. There is one other entity called primary myelofibrosis, which we will not be discussing. Among this, we are going to take up the topic of CML, that is chronic myeloid leukemia. So why does this CML happen? It's because of a genetic abnormality, which is called a balanced translocation of the chromosomes 9, 22. So this has caused the abnormal proliferation of myeloid series of cells causing CML. So what does this and how does this happen? So let's see in detail about this mechanism by which this translocation has happened. We will take that this is the chromosome 9 and this is the chromosome 22. So this is the 9th chromosome, this is the 22nd chromosome. This has a P arm, that is a short arm, and the Q arm, that is the long arm. So the 9th chromosome has ABL gene. It is otherwise called as Abelsen. The 22nd chromosome has BCR, that is breakpoint cluster region. Breakpoint cluster region. So when there is translocation, that is balanced translocation of these two genes, what we get is BCR ABL. And this is the sole reason for this abnormal proliferation of cells in CML. So how does this chromosome after translocation looks? Because it is a balanced translocation, we get two different chromosomal abnormalities. One is the 9th chromosome gaining a Q arm, that is 9q plus, and the 22nd chromosome losing a part of its Q arm, that is called 22q minus. This 22q minus is the one wherein we have the BCR-ABL translocation. This is called the Philadelphia chromosome or the PH chromosome. Philadelphia is the name of the place wherein this was discovered. The 9q plus or otherwise the ABL-BCR is not clinically important, and this does not cause any abnormalities in cell proliferation. So the sole reason is the PH positive chromosome, that is 22q minus. So this is otherwise called as Philadelphia chromosome. So in detail, let's go into the mechanisms of how this translocation still causes this proliferation. So the 22q minus means there is a chromosome which has DNA. So let's take this is the DNA, which is double stranded. The double stranded DNA gives rise to single stranded mRNAs. So this mRNA in turn gives rise to the proteins. So these proteins are from the DNA. So what happens here is a hybrid DNA gene, that is the BCR, the ABL. So this gives rise to the transcript and the abnormal protein. So let's discuss this in detail. So how all the transcripts differ in different proteins. So the most common protein, which is called the P210, the 210 denotes the kilodaltons or the weight of the protein. This is because of the joining of the BCR and the ABL at different regions. So let's take, this is the BCR gene and this is the ABL gene. The BCR gene is denoted by the letter E. The ABL gene is denoted by the letter A. Initially this was termed as B, but later was changed due to some genetic reasons to E. So the ABL gene always gets broken at A1, A2 junction. So always the A2 joins with the BCR gene. So this E can be cut at multiple points. It can be E1, it can be 13, it can be 14 and 19 and so on. So when we combine these both, what you get is a hybrid, that is E13 or 14 with A2, which gives rise to the protein called P210. The next combination is E1A2, which gives rise to the protein called P190. And the next is E19A2, which gives rise to the protein called P230. So these three are different proteins which are expressed in different types of CML. These are grouped under a common heading called typical transcripts. So these three are called typical transcripts. Again, 210 is called as major transcript. The 190 is called as minor transcript. This is how the transcript is being represented. And 230 is called as micro transcript. So these three are different types of the typical CML transcripts. There are also other transcripts which are called atypical transcripts. Atypical transcripts are because of the breakpoint in the BCR gene and the ABL gene are not as these three, E13 or E1 or E19 combining with A2. So any ABL gene being cut at other regions not being A2 are possibly atypical transcripts. So you also have other transcripts called atypical transcripts. The clinical relevance of these we will be discussing later. So we have discussed about the DNA, that is the translocation, followed by the transcripts and the proteins. Now we will go into certain variants of this. The first variant is called a pH negative CML, wherein you are not finding a pH positive chromosome, that is, you are not finding a 22q- in your karyotype. Why so? There is a micro translocation, means the translocation is not being picked up by your karyotyping. But still, there is a translocation which has happened at the microscopic level, which is well enough to give rise to the proteins which are normally seen in the CMLs, that is the BCR-ABL hybrid. So a micro translocation which is not picked up in karyotyping, which is denoted as pH negativity, is still capable of producing a BCR-ABL hybrid, giving rise to CML. What is the second variant? The second variant is because of pH negative complex translocations, means what we normally see is a 922 translocation. There are also other chromosomes which can be involved, and these are called as complex translocations. That is, translocations can involve 3 chromosomes. It can be 9, 14, 22 and so on. Such complex translocations do cause a picture which is similar to CML because of the hybrid gene BCR-ABL being formed in such patients. What else? We have the third variant called as atypical CML. We have discussed so far about atypical transcripts. Please be sure about the differences. What we are discussing now is atypical CML. What is atypical CML? Basically, such patients have clinical features suggestive of CML like splenomegaly, pallor, weight loss and so on, but they don't have any evidence of a hybrid BCR-ABL being formed. Why so then these patients have such a picture is due to mutations in other genes like SETBP1 and ETNK. These are few genes which can be mutated, which causes picture similar to CML. So we have seen the variants which can also be reasons for CML kind of a picture. This completes our etiopathogenesis of CML. So now let's go on to the clinical features. How do these patients present? These patients commonly present to us at a median age of around 50 years. In the Western world, the age is around 60 to 65 years. Still, the Asian population presents little early at around 50 years. There is a slight male preponderance at around 1.4. These patients are usually detected at an asymptomatic stage. When they do a hemogram or a complete blood count for other purposes, and then they find a high count. But also these patients can present to us with symptoms. So what are the common symptoms? It can be weight loss or profuse night sweats, anorexia, and so on. These are the common presentations, and on examination, what do we get? You get pallor and splenomegaly. So very clearly they do not have lymphadenopathy. If they do have lymphadenopathy, suspect other problems which can be associated with a CML. It can be a blast crisis phase, or it can be an acute leukemia which you are missing. Also, hepatomegaly is rare in CML. So these two are rare entities in an upfront presentation of a patient with CML. So what is this blast crisis? What is this CML, CP, and so on? Is because CML patients can present to us in different phases. There are 3 phases. CML presents to us in 3 phases. The chronic phase, the accelerated phase, and the blast crisis phase. The most common is being the chronic phase. It can be present in around 95% of patients. You usually define the accelerated phase and the blast crisis, and those patients who are not fulfilling the definitions of these two are obviously in the chronic phase. The recent definition of accelerated phase is by modified WHO definition, which has few components. 1. They have their peripheral blast or the bone marrow blast, that is the blast count being between 10 to 19%. Anything less than 10% qualifies for chronic phase of CML, and more than 20% or equal to 20% qualifies for blast crisis phase of CML. And the other thing is a rising or falling platelet count which is unresponsive to therapy. So the initial presentation of a patient with CML is usually benign as chronic phase, with the patients having either low, high or normal platelets, and they do respond to treatment. But when there is a picture which shows us that the platelets are unresponsive to treatment and they go above 10 lakhs or below 1 lakh, then do suspect accelerated phase. And what else can satisfy your blast crisis phase is extramedullary blast proliferation. That is a proliferation of your blast in a lymph node or a spleen or liver. So extramedullary blast proliferation also qualifies for blast crisis phase. Medullary blast proliferation. So this completes the definition of the different phases of CML. The accelerated phase, the blast crisis phase, and the most common chronic phase. So these 3 different phases should also make us understand that patients can be having secondary leukocytosis which are not indicative of CML. Means what? Secondary leukocytosis. A patient who has a systemic infection can present with high counts, which does not mean to us that these patients are having CML. How do you differentiate these patients from a patient with CML? Usually such secondary leukocytosis do not cross a count of 50,000. Rarely they do cross, but most of the times they are not crossing a maximum of around 50,000 of total WBC counts. Also, these patients on their peripheral smear show toxic granules. So these are indicative of that there is a secondary leukocytosis, means secondary to other infections. Well, these patients will obviously have absent BCR-ABL. So absent BCR-ABL translocation. So this is how we differentiate a patient with secondary leukocytosis from CML. Now let's go on to diagnose a patient with CML. From this point onwards, it's going to be more of an MCQ based discussion because each and every point is important for you. So please concentrate on each of these points. So let's diagnose. Let's have a small clinical scenario which we will take up as to how to diagnose a patient. First, this is a 28-year-old female who presents to us with weight loss, anorexia, and on examination she has pallor. There is no lymphadenopathy, and the spleen crosses umbilicus. So with this picture, how do you go on to diagnose a patient with this suspected picture suggestive of CML? First, what do? You get a complete blood count. So what does that show to us? It shows that the patient can have anemia, that is low hemoglobin, a high WBC, that is your leukocytosis, and a platelet which is usually normal in chronic phase of presentation. So this is your complete blood count picture. What do you do next? When you have seen a high WBC count, then you do a peripheral smear. And what does this show? It shows left shift. What does that mean? A normal maturation of a myeloid series of cells starts with myeloblasts. So myeloblast then forms promyelocytes, then myelocytes, metamyelocytes, and the mature forms. So this is the normal sequence of development of a myeloid series of cells. What does left shift mean to us? The immature forms of the cells are more seen in the peripheral blood. So you can see more of promyelocytes, metamyelocytes, and myelocytes in your peripheral blood. Also, you can see some percentage of blasts. The percentage of blasts in the peripheral blood and the bone marrow will define which phase the patient has been presenting to you with. So let's take this patient has presented to us with the 1% myeloblast, and other all cells are in the immature forms, that is the non-blast forms of cells. So what next? You go on to do a bone marrow. So what in bone marrow? You do an aspiration first. You see the percentage of blasts. This is the most important reason for you to do a bone marrow aspiration. Also, you see other cells which can otherwise very well be present in your peripheral blood. Then you do a bone marrow biopsy. Biopsy is important for us to know the percentage and the extent of fibrosis which can happen in any patient with a myeloproliferative disorder. This can happen in a patient with a polycythemia vera, can be in a CML or an essential thrombocythemia or a primary myelofibrosis. So this degree or the extent of myelofibrosis is provided by your bone marrow biopsy. So what next? So let's take our patient had around 2% blasts and MF1, that is how we define or represent the intensity of fibrosis in a bone marrow biopsy, MF1 being a mild or a lesser variant and MF3 being a severe fibrotic changes seen in the bone marrow. So these are suggestive of CML. How do you confirm? You will have to prove that there is a translocation between BCR and ABL by your genetic studies. So the proof is through your genetic studies. I commonly name it as genetic studies because there are multiple tests which can suggest you that there is a BCR-ABL translocation. Let's go into the details one by one. First, it's a karyotyping. What does a karyotyping show us? It shows us the Philadelphia chromosome, that is the PH chromosome or PH positive picture, that is 22q-. So this is obtained through your normal karyotyping. For karyotyping and for this kind of cytogenetic studies, you need a bone marrow aspiration sample for you to confirm this. It can also be done in a peripheral blood. I'll tell you the reasons for getting a bone marrow done for this kind of PH positive chromosomes in the assessment part of this section. After karyotyping, what do? You have to prove that there is a translocation, that is BCR-ABL, and which has formed a transcript, which is the mRNA. How do you prove that? You have to do a qualitative PCR. I'm very particular about this qualitative because you have to find out which type of transcript are you going to deal with in this patient. We have seen that there are 3 types of typical transcripts. Also, there can be atypical transcripts in a patient with BCR-ABL translocation. So the transcript which the patient has to be known prior to the starting of treatment for you to quantify them during the treatment. So you do initially qualitative RT-PCR. So in the qualitative RT-PCR, what do you obtain? You get what is the type of transcript and the protein which is being expressed. Whether you get a P210 protein which is that, or a P190 or a P230. There are multiple MCQs based on this, a P210 being the most common. A P190 is common in acute lymphoblastic leukemia with a pH positivity. An ALL patient can also be pH positive, and the most common protein in these patients is P190, that is the minor variant of transcript. The P230, that is the micro variant of transcript, can have patients who are having neutrophil disorders, and also they are less responsive to your TKIs, which is the treatment of patients with CML. So what next? There are some situations wherein you do not find or a masked kind of a picture where the karyotyping is normal. What do you do then? You do a FISH study. What is FISH? That is fluorescence in situ hybridization, wherein you hybridize the presence of you basically spread out your chromosomes, add on hybrids, add on your primers, which hybridize with these chromosomes to yield a fluorescence. Normally, there are 2 colors which are seen when the 9 and 22, that is the BCR and ABL are separate. When they have formed a pH positive chromosome, that is BCR-ABL hybrid, then both these colors will look a single color as yellow. So this is the reason wherein you get a FISH study most commonly when there is a masked translocation. So these are the genetic studies which are important for us for the diagnosis of CML. So having said this, how do you prognosticate these patients? The prognosis is also already designed by scoring systems. These scores are important for us to know how good is the patient going to respond to us, to our TKIs, and what is the intent of treatment and what can be the outcome if you stop TKIs in such patients. So what are the scoring systems? There are multiple named scoring systems. Those which are important for our NEET or MCQ purposes will be discussed here. The most common scoring system is the so-called scoring system. Then came EUROS, the UTOS, and the current one is ELTS scoring system. The so-called and the ELTS scoring system have the same components. The multiplication factor varies, and thus there is a difference in the value of this risk factor stratification. They are stratified as low risks, intermediate risks, and high risk patients based on the score which you obtain by calculating these scoring systems. What are the components? They take platelets, blasts, age, and the spleen size. So these are the components of so-called and the ELTS scoring systems. So once you have done the scoring systems, what next? You are going to treat this patient. Remember, we are dealing with a patient that is a 28-year-old female who presented to us with picture suggestive of CML. So let's discuss the reports of this patient. So what was her CBC? Her CBC was suggestive of hemoglobin, which is 7.2. A count, the total WBC count being 4.5 lakhs and the platelet being 3.2 lakhs. No, the patient has anemia, has raised WBC and a normal platelets. What does her peripheral smear show? Her peripheral smear was suggestive of left shift possibility of CML. Then you went on to do bone marrow for the patient. Aspiration showed 2% blast. There was MF1 picture, that is the fibrosis extent, and the genetic studies revealed to us that the patient has P210 transcript. So this is how you diagnose this patient with CML. Now you are going to treat this patient. What are the options of treatment which you have for such a patient? There are TKIs which have revolutionized this era of CML treatment since 2001. Previously, CML was initially thought as a disease of death. Then came the drugs like busulfan. Some started radiating such patients. Some used hydroxyurea. Then came the transplant and the changes came up with the origin of TKIs. What are TKIs? The tyrosine kinase inhibitors. So there are 5 tyrosine kinase inhibitors for us for use. Those are the first, second, and the third generation in TKIs. The first generation TKI is imatinib. The second generation TKIs are dasatinib, the nilotinib, and the bosutinib. Third generation TKI is the ponatinib. What does these TKIs or the TK inhibitors do? They inhibit ABL. Henceforth, they inhibit the proliferation of abnormal cells in these patients with CML. So, these 4 TKIs, the imatinib, dasatinib, nilotinib, and bosutinib, are approved in the first line treatment of patients with CML. What is first line? A patient being diagnosed with CML and you are starting your treatment. This is called first line treatment. Once the patients fail a first line treatment, then you change the treatment based on the possible mutation, or empirically if you change, it is called second line treatment. A patient who presents fresh after the diagnosis of CML, these are the drugs which can be used upfront in the first line setting. Ponatinib is always used in second or third line setting. So going into the drugs and the mechanism in detail. So let's discuss about the mechanism of action. All these drugs inhibit ABL either in the reversible or the irreversible forms. They also inhibit other tyrosine kinases like c-KIT, PDGFR, SRC family of kinases. Exception is bosutinib, which inhibits only ABL. It does not inhibit other classes of tyrosine kinases. So this is the common mechanism for all these tyrosine kinase inhibitors. They are given at different doses in the first and second line. Let's remember at least the dose of the imatinib. Imatinib is given at a dose of 400 mg per day. So it can be increased or decreased based on the tolerance, the response, and the patient's compliance. That is how we treat a patient with CML. Other drug dosages you need not remember. Now going into the side effect profile of these drugs. What are the side effects? Let's remember the common side effects which can be useful for us for MCQs. What does imatinib give rise to? Fluid retention, skin rashes, diarrhea, fatigue. These are very common side effects which can be normal supportive medications. This is the first generation TKI. What are the second generation TKIs? We know that the dasatinib, which can cause flu-like syndrome. What else? The most common repeated MCQ question is at dasatinib there is a potential for pleural effusion, which can happen in around 27 to 30% of patients. That responds to diuretics. Sometimes you might have to stop the drug for the patient to recover. What else? Nilotinib. The side effect profile of nilotinib is peculiar. It can cause metabolic syndrome. What are the metabolic syndromes? Hyperglycemia, hypercholesterolemia, hypertriglyceridemia, which can lead on to atherosclerosis. So this is commonly seen with nilotinib. Also, they can have cardiovascular side effects. And very important, arterial occlusive diseases. So peripheral arterial occlusions can happen with nilotinib. Also, a very minor number of patients can have pancreatitis. These are to be remembered for us to answer any question related to the drugs in CML. What does bosutinib cause? Bosutinib causes diarrhea. So diarrhea in bosutinib has been very severe that bosutinib is not commonly used in first line or in second line for our patients. What does ponatinib, that is the third generation TKIs, cause? Few things to remember in ponatinib, it is usually dose dependent. What else? It can cause both artery and venous occlusion. So artery and also venous, which is in contrast to your nilotinib, which causes only arterial occlusion. Here the venous occlusion is not so common, but it still can happen in around 5 to 6% of patients. So these are the most common side effects of ponatinib. Having said the side effects of drugs, let's go on to choose a drug for this patient which we are discussing. And why are we choosing such a drug? We will discuss in detail. So again recapping, it's a 28-year-old female who has been diagnosed with CML. Adding on to the patient, she is recently married lady who wishes to have a child. She is yet to get conceived and her wish is to have a child. So 28-year-old female. So how do you counsel and how do you treat such patients? We know that all these TKIs can cause teratogenic effects. Why do they cause? We have seen that TKIs also inhibit different tyrosine kinase called PDGFR. This off-target effect of these tyrosine kinases is the reason for developmental issues in all these patients. So you cannot give any of these TKIs in a patient who is pregnant. Rather, who has been started on TKIs cannot be taking these TKIs during their pregnancy. So how do you counsel, how do you treat such patients? Now comes the concept of stop TKI. Can we stop? Yes, we can stop a patient who is on a chronic treatment with tyrosine kinase inhibitors. So far, discovery of this imatinib is that it is a lifelong treatment. We were happy with patients attaining their longevity which was equal to the age match controls, but now we have stepped up trying to stop these TKIs. How do you decide on stopping? When do you stop? Let's see. So now comes the concept of TFR, treatment-free remission. For that, you should know what is remission, what is the response, and how do you assess this response. Response assessment. Response assessment starts the day next of your starting of your treatment. You first start assessing for the clinical response the patient has presented to you with splenomegaly. So you can call the patient after starting imatinib after a week to palpate the spleen. You can get a hemogram done to see for the hematological response. So what are the different responses and how do you define and what do they indicate to us? First is your CHR or the complete hematological response. Complete hematologic response. What is complete hematological response? It means that your hemogram has normalized and your spleen is not palpable now. So these two conditions ought to be satisfied for you to call that the patient is in CHR, that is complete hematological response. And you expect at a time frame of around 2 to 3 months from the starting of therapy. What do you do next? You can monitor the cytogenetic response. What is cytogenetic response? The pH positivity of the patient can be quantified, calling as percentage of pH positivity. So when the patient has responded to the treatment, you can see the remaining percentage positive pH chromosomes in the bone marrow for you to quantify the cytogenetic response. So you do a bone marrow for you to find out whether the patient has responded cytogenetically. So this is the importance of getting a repeat bone marrow. But now in the current practices, because we have well studied about the molecular responses, we are now doing mostly a peripheral blood study for the molecular response, and we no longer do a repeat bone marrow for you to find out the response of the patient. Rather, we correlate your molecular response from the peripheral blood to the possible response which can happen in your bone marrow. So we are not doing bone marrow anymore for response assessment. Rather, from the peripheral blood, you do a response assessment, that is molecular assessment. You try to correlate to the possible bone marrow response. So cytogenetic response can be either a complete cytogenetic response. As you know, complete means there are no pH positive cells in the bone marrow. It is 0%. Anything between 1 to 35% is called major cytogenetic response. Okay. So now going on to the molecular response. This is little difficult to understand. Let me put it simple for you to understand. So what is molecular response? How do you monitor? What we did initially was a qualitative RT-PCR. Now we are going to quantitate the percentage of BCR-ABL transcripts in the blood. So the percentage of BCR-ABL transcript. How do you calculate this? You do BCR-ABL copies divided by the ABL, that is the control copies. There can be multiple other controls. The commonly used control is ABL. In the international standards, you can do the percentage analysis for you to know what is the molecular response. So how do you do this thing? In baseline, baseline is always taken as 100%. So whatever the percentage which is expressed in baseline is supposed to be 100%. From this, you see the log reduction of this molecular transcripts. So what is 1 log reduction? You know it is 10%. This is called 1 log reduction. If it is 2 log reduction, it will be called as 1%. So on, 3 log is 0.1%. You can name each of this and also correlate with the possible bone marrow picture which can happen, having said you have not done a bone marrow. This 1 log reduction is usually correlating with CHR, that is complete hematological response. A 2 log reduction means to us you have seen in the peripheral blood the BCR-ABL transcripts is 1%. In this patient, if you do a bone marrow now, you will see a complete cytogenetic response. So a peripheral blood suggestive of 1% of BCR-ABL transcripts translates to the bone marrow picture, which can be showing a complete cytogenetic response. So now you can define the complete cytogenetic response not through bone marrow analysis but through a peripheral blood analysis. Having said, you are doing a transcript analysis. So on, how do you name all the subsequent reductions in the log? 0.001% is 4 log reduction. Can be 0.0032%. It is 4.5 logs. 0.0001 is 5 log reduction. This 3 log reduction, 4 log is named after the numbers. MR, molecular response 3, molecular response 4, molecular response 4.5 and molecular response 5. This molecular response 3 is otherwise called as MMR, that is major molecular response. Those from 4 and so on are called as deep molecular responses. So anything 4, 4.5 and 5 are called as deep molecular responses. The current available modalities can detect a cell up to MR5, not beyond that. So a DMR is, which is either MR4, 4.5 or 5. Why is this important to us? Is to monitor the patient. So the current patient, now we think we have started on imatinib. So this patient which you have started on imatinib, let's do a timeline management. So this is day 0 wherein you have started your imatinib. You have monitored the spleen size and you are doing a regular hemogram check for you to know that the patient is responding to treatment. At 3 months, you expect CHR, that is complete hematological response. Here CBC is supposed to be normal. At 6 months, you expect CCYR, that is complete cytogenetic response, means your patient should have 1% in your BCR-ABL transcript analysis, 1% in your quantitative PCR, RT-PCR. This is how you monitor. And anything as 0.1 or below, less than or equal to 0.1. So anything less than or equal to 0.1% is your goal for any patient being started on any treatment. So this is your goal, that is major molecular response or MMR. This is what you are working towards. But now come back to our patient. She wants to get conceived. What do? Want to stop the patient who is already on a TKI. So how do you stop and when do you stop? When do you stop? Basically, you have to have a deep molecular response, that is MR4 in certain trials, and certain trials used MR 4.5 to define their deep molecular response. This should be attained in a patient, and patient should be in DMR or the deep molecular response for around 2 to 3 years. So if the patient has a sustained deep molecular response, you can try stopping your TKIs. This TKIs, imatinib is your first generation, we know. The dasatinib, the bosutinib and the nilotinib, the second generations, are strong enough to induce a DMR and they show a better result compared to imatinib for patients who are being intended to stop the therapy. So if you wish to stop therapy, you can very well start patients on second generation TKIs upfront. So what after stopping? So now you have stopped. What do you do next? You start monitoring the patient. You monitor the BCR-ABL transcript level. You do the quantitative RT-PCR very frequently. Initially you do monthly for around 6 months, then 2 monthly, 3 monthly and then 6 monthly. You see and confirm that the patient maintains her deep molecular response. But there can be scenarios wherein the patient loses her response. How many percentage of patients can lose? Usually the treatment-free remission is around 40% at 5 years. This is the rough figure which has been got through multiple trials. The trials have tried stopping imatinib, dasatinib, nilotinib and so on, and all these trials have shown a figure of around 40 to 45% of patients being able to maintain their deep molecular response which they achieved prior to stopping of therapy. So they are able to be treatment free for the rest of their life. So far we have a follow-up of around 10 to 15 years, and these patients are maintaining their deep molecular response. What happens to the remaining 60%? They lose their response. When do they lose their response? Usually around 80 to 90% of patients lose their response in the initial 6-month period. So within 6 months, you will come to know that the patient whether he or she is going to maintain the response or going to lose the response. How do you define that the patient has lost response? Any patient who has lost a major molecular response or MMR is said to have lost the response, or any rise in log of the BCR-ABL copies is also said to have lost their response. So how much or how many times do you confirm this? It is a single time value. So you can do a single value which shows that the patient has lost her response. You need not wait for another value to confirm. So once she has lost her response, what do? You restart the patient on TKI. So which TKI do you restart? You restart the same TKI which you have stopped before your stopping story. You have used a TKI, so the same TKI you can restart. Will they achieve a repeat remission? Yes, 95 to 98% of patients will achieve a MMR within next 2 months. Each of these points are well MCQs for you, so please concentrate on this. So what next? If they have achieved their MMR, then go on to do the second or the second generation TKI for some time and try stopping the therapy for the second time. So what predicts this treatment-free remission? Any patient who can have a deep molecular response of around 3 years and who are not high risk in your prognostic scores, low or intermediate risk, tend to do well with your stopping therapy. So these are the predictors of your response to the stopping of treatment. So now that you have tried stopping for this pregnant lady and tried monitoring this patient, you will have to find out whether she is losing her response or trying to maintain her response. This is done frequently with your quantitative RT-PCRs. So this completes our treatment part. Other options of treatment? Yes, these patients can be transplanted. Any patient who presents to us in blast crisis, well, transplant is the only option. Bring them into remission with your chemotherapy, then do a allogenic stem cell transplant. If a patient presents to us in accelerated phase, you can still try second generation TKIs or even a first generation TKI at higher doses, and if the patient responds, you can try maintaining the patient on the same TKI, or if the patient does not respond, try pushing for a transplant. Also, there is a common mutation, that is T315I. This is the mutation which does not respond to any of your first and second generation TKIs. So they respond either to ponatinib or you will have to transplant the patient. So these are the other options for such patients. Thank you.